Thank you, Paul, and thank you, everyone, for coming out today. We're going to just keep marching up the body to the head now. And I think the theme that we've been getting from most of these talks is that the goals of our surgeons the goal of our surgeons is to deal with the pathology, the problem, but leave the patient otherwise as intact as possible. And so trying to do less with surgery and achieve the same outcomes. And I wanted to talk a little bit about brain tumors that are not cancer, because people think of brain tumors and they think of that's the worst that can happen. That's how you end a soap opera star's career, is you give them a brain tumor. And so the point is I want to talk about some of the things we treat that are not, and to distinguish cancer versus not. I have the disclosures. None of these is really particularly relevant, except maybe the microrobotics that I've consulted with a French company there. But when people think of brain tumors, they think of this kind of malignant tumor that is cancer. And although primary brain tumors don't tend to spread to other parts of the body, they can be very aggressive. And even if we can take them out with surgery, like you can see here, it's usually requires additional radiation, chemotherapy, and they tend to be tenacious and recur. But the truth is that most tumors are not cancer, are not malignant in the brain. The majority, about 70%, are benign tumors that can be effectively cured with surgery, or at least treated without need for additional treatments. The most common are meningiomas, and I'll show a little bit examples of that. Pituitary tumors, tumors arising from the nerve roots are also common, these nerve sheath tumors. And this is just the breakdown. People tend to present with benign brain tumors similar to the way they do with malignant ones, where there are focal signs, right? Depending on where the tumor is, it'll compress the brain or structures surrounding it and cause deficits related to the function of that normal tissue. Sometimes they'll grow to sizes where they'll cause mental status changes or headaches from the pressure they're globally placing on the brain. Sometimes irritation of the nerves will cause propagation of electrical signals that are abnormal, and that manifests as seizures, which can be partial or general. Sometimes they're incidental. This was a database from emergency visits, and many were incidental. They were just found in patients who came in because they had a car accident or a fall. And then also related to high pressure, patients can have nausea, vomiting, or dizziness. But I want to reassure you that many of these symptoms, particularly headaches and nausea, don't necessarily mean you have a benign or malignant tumor. The neuroanatomy is important in understanding when you meet a patient where the tumor likely is, and although we have imaging now that does much of this for us, figuring out who needs an image and what kind of image to get. These are different views of the brain from the outer surface on the left and the inner surfaces on the right, and you can have these tumors anywhere. They are outside the brain, right? These non-malignant ones generally, although not always. And so you might have someone have, I don't know, is there a pointer, is there a cursor coming up here? I don't know. Anyway, so you can see that there's, on the undersurface of the brain, you have many of the cranial nerves, which involve things like olfaction or vision or movements of the face or hearing. And then within the brain, you've got primary centers where motor function is regulated, or sensation, or vision, or decision making. And so that will often impact how people present. Depending on where the tumor is and what kind it is and its size and a number of other factors related to the patient, sometimes they don't require surgery, either because they're small and not symptomatic, or because they are in a place where we can radiate them. We can treat these and stop them from growing in their location. Now, often symptomatic ones, we can't do that, but because they don't tend to shrink, they just stop growing. But this is an example with modern techniques, and we saw what Dr. McGibbon was telling us about radiation for other diseases. But even for these benign tumors, you can create a very we call conformal or well-shaped beam that strikes the tumors with very minimal radiation to surrounding structures. In terms of how we approach them as surgeons, when patients need surgery, it has a lot to do with the location, almost all of it, right? Our goal, again, is to try to get the tumors out with as little damage to surrounding structures, and the approach can be part of that risk. So these are anatomic dissections from a famous neurosurgeon who did these named Albert Roten. And you can see that tumors along the convexity of the brain can be relatively accessible, but ones that are going to be deeper, kind of along the concavity, are going to be a lot more difficult to reach from the outside. And that'll guide us to sometimes take approaches through existing orifices like the nose. And I'll talk about that with some videos in a minute. So again, just to summarize it, this is like what Dr. Merrill was showing, a sagittal or view from the side of the brain. The patient's pointing to or facing to the left here. And so depending on where the tumor is, we'll come with a relatively simple approach from above, or sometimes we'll have to come from below, which can be from the sides, or sometimes up the nose, requiring no external incisions. So this was a 58-year-old woman who presented with confusion, speech problems, and this goes to show these tumors, this is a benign tumor, but because of its location, it grew to a pretty significant size before anyone, the patient or her family, realized there was anything there. And so this was about the size of a baseball in respect to our next speaker. And we were able to get to it, though, pretty easily from the outside, from above, just a small incision on the top of the scalp and removing the bone over it. And you can see you can get a complete resection, and she'll hopefully require no additional treatment. Sometimes, though, these tumors, even though they're benign, are in very tricky locations. They can be along the base of the skull and causing pressure on the brain around critical structures. And it used to be that these would require massive surgeries, but over the last really 2 decades, technology with endoscopy and other minimally invasive techniques have allowed us to approach these and get excellent resections without requiring big incisions. And this is an example of a meningioma that's really right back there along the base of the skull. And this shows the view from the endoscope inside the nose. And actually what we'll do, because we're removing these tumors that now communicate in space with the nose, we will take a flap of the mucosa down that we can then use to reconstruct the base of the skull. And this shows, this is some technical terms, but looking up through the nose at the base of the skull, we remove the bone and expose the outer surrounding, the surface of the brain, the tissue surrounding the brain, and we're already in the tumor. We haven't even looked at the brain yet. So these different techniques allow us to do this, to approach these tumors with not just minimal, but in this case almost no contact with the brain. And we're able to now, once we've debulked the tumor, come around it. And you'll see here now some of the normal structures. We're able to dissect it off of the frontal lobe in this case, and that's the anterior cerebral artery, one of the major arteries of the brain. And as we are able to cut its attachments, you'll see here the anterior communicating artery, and that's the optic nerve, and the optic chiasm is where the left and right optic nerves come together. And we're able to remove this tumor completely. And you can see that the imaging from this, it never got resections like this because we're actually removing the origin of the tumor at the bone. This is another type of tumor in a similar location, but that's growing up from back at the kind of very back of the nose up into the brain in a very deep area. And you can see this would be a very long reach from above. And yet, coming in through the nose, we're able to get to this. And this is a tumor that originates from the pituitary stalk. And historically, this shows you the kind of opening we would need to really get to this tumor. And you're exposing the frontal lobe here and the temporal lobe. You see the orbit and the eye exposed on this diagram. And this is the big challenge, is that you've got the optic nerves and the carotid arteries and all these critical neurovascular structures between you and the tumor, you as the surgeon. And so you're working through those very narrow corridors over hours and hours, trying to get to this tumor beyond them. And this is an intraoperative photograph. I'm not sure how well it's projected, but you can see the optic nerve splayed by this tumor. And so coming from above, you really don't have great access to this, but coming from below, you get a view directly on the long axis of the tumor, and you're able to see those critical structures and not have to work beyond them. You don't have to pass them every time you're coming in and out. And data is important, right? We we love this idea of minimally invasive, but does it really lead to better outcomes? And this is a table showing the difference for this type of tumor between the open craniotomies and these endoscopic approaches. And although the leak rate was a little bit higher, or quite a bit higher with the endoscopic rate, we've brought those down over the years, they did lead to better outcomes with regards to vision, tumor recurrence, and some of the endocrine problems that can come up. And this is another one. This is an example of one of those craniopharyngiomas that you can access through the nose, and this will skip some of the exposure, but here you can see the optic nerves above the tumor there, and we're working on the tumor itself. You can bipolar it. This is to take away the blood supply, debulk it, and then access it, and this is coming up. I don't know if it may be hard to appreciate, but you're coming from beyond the optic nerves into deep within the center of the brain here. You're looking through in a view that shows you to the back structures of the brain, something called the aqueduct. And you'll be able to see here with the origin of the tumor, we can actually cut that and remove the entire tumor in this case. So this is dissecting off the walls of the third ventricle, which is where the hypothalamus is, which is part of the brain that involves hunger and body temperature, and that's the view of the tumor out. We talked a little bit. We heard from Dr. Held about robotic surgery in the knee. Robotic surgery in neurosurgery, we use it quite a bit in the spine. It's really good for perfect trajectories. Unfortunately, this is in a cadaveric model. Some of the robotics, they're still a little bit too large for the narrow corridors that we work in. But that technology, I wouldn't bet against it. That's definitely, I would say, over the next 10 to 15 years, going to be a big part of what we're doing. So to conclude, benign doesn't mean harmless, right? The pressure from these tumors can be significant. They can be stuck and hard to remove. But referring them early and discussing the treatment options is important. The location is critical. And we're fortunate here at Greenwich Hospital to have a really great team that includes neurosurgeons, endocrinologists, ENTs, the nursing staff, physician assistants, and physical therapists that really bring these patients to great outcomes. So, thank you.